Let's talk about complications that can happen with fractures. The first and most common is neurovascular compromise. Neuro meaning the sensation and movement, and vascular meaning circulation. We can check for neurovascular compromise through the 6 Ps listed on page 1236 of your text. Those 6 Ps are passive pain at rest with pressure, paresthesia, meaning tingling or lack of sensation, pallor, meaning poor coloring, paralysis, lack of movement, and pulselessness. Now we can think about those 6 Ps, and we can also assess for neurovascular compromise using a CMS assessment: circulation, motion, and sensation. You can check circulation by checking cap refill distal to the injury. You can check for pulses distal to the injury. And you can look for the coloring of the skin distal to the injury. That all checks for circulation. Now for motion, you ask them to wiggle their toes, wiggle their fingers, whatever is affected. And then you would touch their fingers or toes, whatever is distal to the injury, and say, can you feel me touching? And they'll say yes. And then you know that you have good CMS. And when I see fractures in the ER, that's something I always assess for. And I always document that CMS is intact, noting that there's no problems with neurovascular compromise. Now, venous thromboemboli are deep vein thromboses, and these are clots that can happen, especially due to immobility and lack of movement. And these clots can often be that can build up in the legs and the calves. And you can know that if you have a DVT, you're going to assess for things like warmth, redness, and swelling of the leg, also pain. Now, a fat embolism can occur after a long bone injury that a patient has to go to surgery. And so a part of that fatty bone marrow exposed because of the break in the bone actually floats out into the bloodstream and causes a clot, just like a DVT would. And remember from our perfusion lecture that one of those causes for poor perfusion are clots in the bloodstream. So both DVTs and fat embolisms can cause clots, which would mean a lack or poor perfusion. Traumatic rhabdomyolysis. So anytime that there's this musculoskeletal trauma, the muscles themselves can become injured and cause breakdown of those muscle cells. One of the breakdown components of muscles is myoglobin. Myoglobin is a big fat protein cell. And those myoglobins, when released from crushed injured muscles, can actually clog up the kidneys, and the patient will have dark Coca-Cola colored urine, significant pain, and is at risk for kidney injury because their kidneys are just full of these big fat myoglobin cells that happen from muscle breakdown when muscle trauma, especially crush injuries, are involved. Now, hypovolemia, low fluid volume, is another complication from fractures. If a patient has an open fracture, of course, open fractures are going to bleed significantly and they can bleed out that way. But the patients who have closed fractures, fractures that there's no break in the skin, can also bleed out because the sharp edges of those fractured bones could actually pierce through an artery internally, and we wouldn't see it, which is why we need to have a high level of suspicion on all fractures and monitor vital signs closely. The signs we would see if patients were struggling with hypovolemia, things like low blood pressure, tachycardia, but especially that blood pressure, altered mental status. We would want to be very aware of any signs of hypovolemia, which you learned in your FUNS class. Now, of course, patients who have open fractures or have to go to surgery are more at risk for infection because there's a new portal of entry. And then this risk for malunion or non-union. Malunion meaning the bones didn't line up great and the patient's always going to struggle with that because it didn't heal well. Or non-union, where those bones never met back up ever. And again, the patient is going to suffer long-term disability when that happens. We teach you in your 110 course about predicting potential complications, and compartment syndrome is a major complication that we need to predict and assess for anytime we have a fracture. When we have a fracture, the acute inflammatory response happens, and we know that part of that inflammatory response is bringing extra fluid to the area, and the area is going to swell, and that's part of the body's normal healing process. But when we put a cast on that area, we've now created a closed space, and that injury can't swell beyond that closed space. And when it gets too swollen, and if the cast can't expand, then we can get something called compartment syndrome, where there's just this excess fluid building up in these spaces and there's nowhere for it to go. And this eventually can lead to lack of perfusion and necrosis, tissue death. And so we want to have very good sense of CMS, circulation, motion, sensation, watching for those 6Ps, and making sure that if we're noticing that the cast is getting too tight because the patient is swelling, that we intervene quickly to relieve some of that pressure and call the surgeon. Now, sometimes relieving the cast itself isn't enough. Sometimes just the compartments within that muscle, within that tissue, become too tight and pressurized with all this fluid. And the surgeon actually has to perform a fasciotomy to relieve pressure over those compartments within the injury. Now, another risk, we talked about DVTs and fat emboli, but what can happen with these DVTs is they can break away, travel through the bloodstream, and you got it, land in the lungs. And then they're called pulmonary embolism. Now, pulmonary embolism can cause significant risks and even death. Patients who experience pulmonary embolism are going to be short of breath. They're going to be tachycardic. They're going to have abnormal breath sounds. They might have some chest pain, some cyanosis, blue around their mouth, blue on their fingers, certainly anxiety, and even some altered mental status. And this all happens due to the hypoxia and impaired gas exchange that can happen with a pulmonary emboli. Now, if left untreated, this can actually lead to death, and we want to make sure that we intervene quickly. Pulmonary embolisms are going to be first identified with just an assessment, recognizing this poor gas exchange and these signs and symptoms. And they can be confirmed through a blood test called a D-dimer, and then definitively confirmed through a CAT scan of the lungs. Now, a pelvic fracture is particularly high risk for hypovolemia. The pelvis is extremely vascular. There's a lot of blood flow through our pelvis. And so if the patient has a pelvic fracture, they can hemorrhage and bleed out internally very quickly. So we want to have a high level suspicion for pelvis fractures and recognize any hypovolemia or hypovolemic shock, which is really bad, hypovolemia, and intervene quickly if that occurs. So we've talked about what causes fractures, different kinds of fractures. Now we want to get in and some of the complications that can happen from fractures. But now we want to walk through that nursing process as always to get a sense of our responsibility and role in fracture care. So first we assess and analyze, and assessments are going to reveal the extent of the injury based on the physical manifestations. You may see localized swelling. You may see localized deformity. You may see an open wound. The patient's going to be showing signs of pain or reporting signs of pain. The patient may not be able to move that certain area of their body, or you might notice poor pulses in that area of the body, a poor CMS exam. And so all of these things are what we're going to be assessing as we're looking for patients who have a suspected fracture. Our nursing problems, things that we have control over and need to take action on, things like acute pain, activity intolerance, impaired mobility, and impaired skin integrity are all options for nursing problems, nursing diagnoses. What are we going to assess? I think you've heard multiple times in this lecture that we wanted to really be careful about those vital signs because of the risks for things like PEs and hemorrhaging. We want to watch those vital signs. Those vital signs are going to give us cues into how the patient is doing. We're going to perform a physical assessment, and that's going to include look, listening, and feeling. And then we're also going to find out about the mechanism of injury, how it happened, when it happened, and noting any deformity, swelling, redness, pain that the patient might have. We're going to verify proper positioning. Sometimes just putting a patient's appendage in some position of comfort can significantly reduce the pain that's involved as we're acutely treating them. And so this can be done with splinting, slings, casts, but this is something where we would work collaboratively with the provider to ensure the appropriate positioning. We would want to do lab tests so we can check our white cells for risk of infection. We can check a D-dimer if we're concerned about a pulmonary embolism. And we can check hemoglobin if we're worried about anemia related to hemorrhage. We want to look at their urine appearance. Remember, if someone's having rhabdomyolysis, where there's muscle breakdown from crush injury, where those big muscle proteins, the myoglobin, are floating through the bloodstream, the patient's going to have dark Coca-Cola colored urine. And then, of course, we're going to monitor the patient's input and output. Now, here are some actions that we can take, some nursing interventions that we can do. We want to maintain pulmonary hygiene. Just like anyone else who has some kind of surgery or is hospitalized, we want to encourage coughing and deep breathing so they don't end up with a pneumonia on top of everything else. We want to administer analgesia as ordered. Pain management should be a top priority after the ABCs for these patients. Administer any other medications as ordered. They might be on antibiotics to prevent some kind of infection, or some kind of blood thinner, an anticoagulant to prevent DVTs like heparin. We want to do proper wound or pin care if indicated. Elevate is part of what we know about inflammation. We want to rest, ice, elevate, and compress. And so we can elevate the appendage to help reduce that inflammation and swelling. We can apply ice, maybe 20 minutes every hour. Perform range of motion exercises to keep limbs moving. Reposition for comfort and also to prevent skin breakdown. Providing hydration and nutrition, because we know that tissue integrity and wound healing needs proper nutrition, especially protein and hydration, in order to heal appropriately. And then provide positive feedback and encouragement, because we can't forget about the psychosocial part of this. It can be very traumatizing for a patient to have a broken a fracture, and then the lifestyle changes that have to come from that. Okay, teaching. One of my favorite parts about being a nurse is we are constantly teaching. It's part of what we do as interventions. Here's what we're going to teach. We're going to teach the treatment process, the healing schedule, what they can expect, and how often they'll come back for visits, and what each visit might look like. We want to encourage them to consume adequate calories to help for bone and tissue repair. How to teach the patients how to appropriately use their analgesia. Many patients are going to be sent home on some kind of narcotic medication, and we need to teach them proper storage, how to write down when they had it so they don't overdose, and how often they can take it. What wound care is involved, especially if they had surgery or some kind of open fracture. What kind of exercise activities and ambulation, do they have any activity restrictions? And if so, how can they manage? Do we need to teach crutch walking or walker care? What is it that they're going to need in order to maintain their ambulation? And then same thing here, proper use of slings, splints, casts, and tractions. And anytime we send patients home with some kind of splint or cast, you want to say, if your fingers are tingly, like broken arm, if your fingers are tingly or turning cold, you need to loosen that bandage or come back to the ER, come back to the clinic right away, because it's too tight and we don't want it to cut off circulation. And then we want to teach patients how they can continue to care for themselves while they're dealing with the recovery period. Remember, bones don't heal all of a sudden overnight. This is typically a 4 to 8 week process before patients are really recovered. And then how do we evaluate? How do we evaluate if we did a good job, if we did what we were supposed to do as nurses? How do we evaluate their care? Well, the patient's going to remain free of infection. They didn't get an infection. That's good. They're using the analgesia, the pain medication as ordered. They're not overdosing. They're not misusing it. They're storing it properly and keeping it safe. There's no neurovascular compromise. They've got good CMS. Their CMS is intact. And they're free from those 6 Ps that we talked about: pain at rest, pressure, paresthesia, pallor, paralysis, and pulselessness. They're getting good nutrition and compliant with their exercise and activity protocols. And here's the keys, because this is the ABCs. They've got stable vital signs. That's really important. Their intake and output is normal, and they're showing signs of good perfusion. And that's all you need to know about fractures. We'll get into this more in class. Thanks for listening, and I'll see you next time.